Hi, my name's Evelyn. This is my epidural spinal video. If I was doing an OR procedure, I do a machine checkoff. So I'd make sure it's plugged into power, I'd make sure I have my ambu bag, I check my tank pressure, so my nitrous should be above 745, my oxygen should be above 1,000, and then my pipe gas pressure should be above around 50 psi. And then I should fill my volatile gases, make sure the cap's screw on tight, check the interlock system, and then I need to do a low pressure leak test, and that will pass. Then I can turn on my machine, I can check my flow meters and check my link 25, and then I can check my O2 analyzer, CO2 absorber, and then my scavenging system. Those will all pass. And then I want to do a high pressure system check. So I will close my APL valve all the way. I'll O2 flush until the system is 30 centimeters of water. That should hold for 10 seconds. And then after that, I know it's passed, and I can check my bag and my mechanical ventilation on this machine. So that will pass. If I was doing like a C-section, I'd have some meds. So I'd have some midazolam, fentanyl, lidocaine, propofol, rocuronium, Sevo, and Zofran, and some emergency Apple drugs, so atropine, sexacholine, ephedrine, epinephrine, and phenylephrine. I'd have some blades, some ETT tubes, LMAs, and then I want to make sure I have all my supplies, so PPE, my epidural kit, and my spinal kit, and any other drugs that I would need for this procedure. So now I can go and talk to my patient. She's just getting she's doing a vaginal birth, but she would like an epidural. So she's a 27-year-old female, 50 kilograms, ASA 1, BMA of 24. I'll just go and introduce myself. We'll go over medical history, medications, allergies really fast, and then I'll just assess that she had routine labs done and that she's not anticoagulated or low on platelets, because if she is, this is a contraindication for these two procedures. I'll do a quick physical assessment. I'll listen to heart and lungs, do an air rate assessment, and then I'll also make sure she's fit to do this procedure. She's not too anxious, she can sit up or lay down and hold still. After that, I can go over the consent and plan with her. So we'll talk about the rationale of this procedure. Since she's doing a vaginal birth, it's for pain control. She's doing a C-section, it'd be for post-operative and intraoperative pain control. Some alternatives to this are, you could have the surgery without the epidural, but you might have to go under with general anesthesia. And then you could use opioids, relaxation techniques as alternatives. And then for the procedure, I need you to sit in a C, hunched over. I need you to hold still, and I'll just put a catheter in your lower back area to help manage the pain. Some of these risks are nerve damage with this procedure. These are all low, but potential. You could get a hematoma, spinal abscess, total spinal, backache, hypotension, bradycardia. This could not even work. It could fail. It could be a partial. Nausea and vomiting. Might be a little bit more painful than average on placement, depending on anatomy, infection, difficulty breathing. So I'd go over all those risks, but they explain they're low risks. And then I'd go over some benefits. So general anesthesia might not be required for surgery. You could just rely on this if you were doing a C-section. And then I just want to make sure this procedure is appropriate, the patient is appropriate for this situation, and then ensure that she understands and is fully aware and she's the one that is consenting, and I would obtain consent and then proceed. So to start, I'd sit her up, and I would make sure that she's hooked up to oxygen and EKG and supplemental O2 if she needs it, and that it's audible so I can hear any change in status. And then I have the patient trying to hold still, hunch her back so I can get her in the best position for this puncture. But I identify landmarks. So I need to identify my two Fears line, which would be your top of your iliac crest drawn across, or your intercostal line. And that should show me roughly where L3 to L4 is. And since I'm doing a midline approach, I need to be just right in between those spinous processes. So once I find that, then I can mark that spot with the cap of a needle and press it in so it makes an indentation in your skin. I'll just tell her to hold still, and I'm just gonna prep my kit really fast. So I'll sterilely open my epidural kit. While she's sitting there, I don sterile gloves, so I'm sterile. And then I'm just gonna tell her that I'm gonna prep really fast. So I'd find that spot again, use my iodine, inside to outside circles, inside to outside circles, inside to outside. And then I let that dry and I tell her to hold still while I finish up prepping my kit. So now, all of these ampules in my kit I need to draw up with a filter needle. So I'll first start with my loss of resistance needle, and I'll just use my filter needle, drop some NS or sterile water to lubricate it and make sure there's no stickiness. And then I'll use my filter needle to draw up about 4 mils of sterile water or NS in this, and that's prepped. So then I can take my local needle, and I'll take my filter needle and draw up my 1% lidocaine, about 3 cc's of this, and after that I can switch to a 25 gauge needle, Once I have that, then that is ready to go and prepped. My last needle that I want to prep is my test dose. So for my test dose needle, I'll take my filter needle and I'll draw up 1.5% lidocaine with 1 to 200,000 of epi added in. And so if I drew up 3 mils of that, which I do for my test dose, I'll have 45 milligrams of lidocaine with 15 micrograms of epinephrine total. So now that I have that drawn up, I'll drop some more NS in this filter needle, prime my filter, prime my connection tubing, pull out my sticker, and then this should be all dry by the time I've done all that. So now I can drape her. So I'll open this drape sterilely. And I'll drape it over my mark that's still there. So that's draped over my mark. She's still sterile. I'm ready to begin the procedure. So now I can take my loss of resistance needle and my TUI needle. I'm just gonna hook this needle on and then take my lidocaine and numb up the spot that I marked. So I'll inject my local, angle slightly cephalad, and it'll be a similar path as my TUI needle. So now I'm done with this local. I can use the bromage technique and I'll insert my TUI needle, angled slightly cephalad, bevel up, and then I'll also be pumping the syringe to check for loss of resistance as I insert centimeter by centimeter. And then I'll just go through the supraspinous, intraspinous, and then the ligamentum flavum, and that will be the pop and loss of resistance that will show me I'm in the epidural space. So, bromage technique, I'm gonna do another palpation just to make sure. Angled slightly cephalad, all the things I said. And then I'll just be pumping slowly as I go until I get a lot of resistance. Okay, and it looks like I have loss of resistance and I'm about 2, 3, 4, 5. Okay, so I'm 5 centimeters in, which means I have 4 centimeters of needle in the patient. So I just need to make sure that I have that. And then once I am in the right spot, now I can aspirate this needle for blood or CSF. And if I get blood or CSF back, that means I'm in the wrong spot and I need to figure that out, and I accidentally wet tapped them. So once I have that, I can unhook my loss of resistance needle and I'll take my epidural catheter and then I'll just thread it in. And because this is in the patient 4 centimeters, the epidural should be sitting in the epidural space around 5 centimeters. So I need to do 5 plus 4. So I need this to be around 9 centimeters. So I will thread this in. So once it's about 9 centimeters, then I can remove my TUI needle carefully and make sure I don't dislodge my epidural catheter from the space that it's placed. So now I'm just slowly kind of feeding the catheter as I pull it back. So now once the TUI needle is out of the skin, I can grip the epidural catheter and then take the TUI needle off and manage the rest of that wire. So now I can double check my placement, make sure it's still at 9, and then I can secure this to the patient sterilely, use a sterile dressing. And then once that's secured, then I can take the drape off. So now the drape's off, I'll just connect these connector and filter that I primed at the beginning. And now I just want to talk with my patient and have them inform me about symptoms they may experience that will clue me on if this is in the right spot still. So the first thing is if I accidentally put the catheter in the intravascular space and I'm about to do my test dose into that space, the heart rate will increase because of the epi, and they might get a metallic taste, ringing in their ears, dizziness from the local anesthetic, and then if they're in the intrathecal space with the catheter, they'll feel really warm and heavy in about 30 seconds in their legs and like lower body, and it might spread higher than expected, so they might get hypotension, bradycardia from the local, but the epi in this space won't do much intrathecally besides maybe prolong the block. So once I have my patient kind of communicating with me and I'm watching for those things, then I can give my test dose. So I'll give my test dose And then I'll just keep watching the patient for 3 to 5 minutes and see if any of those side effects happen for intrathecal intravascular reaction. And then after that time has passed, I can position the patient back into a comfortable position and administer an appropriate first dose. So my first dose will be bupivacaine, 0.25%, and that will be 8 mils. And then added to that will be fentanyl, 100 micrograms, and that will total of 10 mils. So that I need to give over 5 to 10 minutes, 2 mils at a time, and just keep monitoring the patient. So I'll note vital signs and the patient comfort level every 5 minutes for about 15 minutes, and then I'll just make sure the epidural is labeled and I charted the procedure. So I can continue taping this up the patient's back and just secure a little better, but that's epidural. So now if I'm doing a spinal, it's pretty much same setup. So I won't open this yet. This is my spinal kit though. I'll have this ready. I'll set the patient up. We'll identify the same landmarks, 2 Freers line, L3 to L4, midline approach. So then once I pick my spot, I can mark it with a needle cap, and then I can tell the patient to hold still and open my kit again. So I'll sterilely open my kit, don sterile gloves, and then I'll do some more sterile prep. So iodine, inside to outside, inside to outside, inside to outside. I'll tell the patient to sit still while that dries and tell them I'm prepping my kit. So now, same thing, I have my filter needle that I'll use to drop my lidocaine. So I'm gonna use lidocaine 1%, 3 mils again to numb the skin. And then once that's drawn up with the filter needle, then I can put a 25 gauge needle on there, and then I can draw up my hyperbaric spinal. So that's my bupivacaine 0.75% with dextrose 8.25%. So once I draw that up and label it, then that's ready to go. Then at this point, this will be dry, so I can drape my patient. So now I'll sterilely drape my patient. And ensure that my marking is still there. So now I can numb the spot that I marked. So I'll numb this with my local, and then again using the bromage technique, I have a introducer needle, and I'll use the bromage technique to insert this cephalad at the marked spot slowly, depending on how heavy the patient is, how deep I need to go. And I'll just use discretion depending on my patient's weight and BMI. So I can take off this needle, and then I'll take my spinal needle and I'll insert that, and then slowly advance both of these and the spinal, checking to see if there's CSF return. So I'll advance, check to CCFF or CSF, and then once I feel loss of resistance, that's sometimes a sign that you're in a good spot, or you need to go a little further, or a good frank CSF is another sign you're in the right spot. So once I have CSF, I can take out this little introducer thing in my needle, and I can get my spinal, and I'll attach it to my spinal needle, and then I'll aspirate, and because it's a hyperbaric solution, I should see swirlies in this vial. So once I see swirls, I know I have CSF return, so then I can inject half my spinal, and then I'll aspirate one more time just to double check, and then I'll inject the rest of my medication. So once I have that done, I'll explain to the patient that the medicine is in, I'm taking out the needles, so I can remove both of the needles, take the drape off the patient, and then reposition the patient until they're in a comfortable position. And then I just also want to note the vital signs and the patient comfort level every 2 to 5 minutes and chart the procedure.